The AWARE project's aim is to balance the public conversation about psychedelics, spread accurate information, and give a new face to psychedelia. We feel that this change will occur through connection and relationship, one individual at a time. We are calling on everyone whose lives have been improved through the mindful use of psychedelics to educate themselves and become ambassadors for the psychedelic experience. Show those around you that people who use psychedelics mindfully cross all social, racial, economic, and political boundaries.
Cole and a number of other people in the audience too are also part of the MAPS Phase 3 trial for MDMA-assisted psychotherapy for PTSD. MAPS is finishing up their Phase 2 trials right now, which have been looking really great, and they'll be finishing that up by the end of the year. And then we'll be starting this Phase 3 trial in probably like late spring next year. And it's really exciting because no other psychedelic has made it this far through the FDA system. So I'm really excited to see that progressing, and then we're also really excited that one of the sites is going to be here in Los Angeles. So super cool. So yeah, Cole and Wes.
Hello. Well, thanks for having us here. Ashley has really put together an amazing community and has met a lot of really cool and interesting people here. It's a pleasure to be here presenting. And just a plug for if you approve of the Zendo project and want to donate, there's like somebody's matching donations up to I think $15,000 right now. That's at zendoproject.org.
I think they're doing that for the next week or two, so sooner the better.
And hold it close to your mouth.
Okay, thank you.
Oh, sorry.
All right, so we're going to be talking about ketamine and depression. Ketamine was originally developed as an anesthetic in the early 70s and has recently found a lot of promise as an agent for treatment-resistant depression. And Wes and I, during our training as residents, wrote a review article reviewing all of the existing literature. And we looked at a lot of different aspects of ketamine for depression, and it's actually going to be, so a lot of what we're presenting today is originally published in the International Journal of Transpersonal Studies, and is also going to be published as a book chapter, Ketamine for Depression being published by MAPS sometime this year.
Yeah, here you go. If anybody wants to check out that initial article that Cole was just mentioning, I've got a link to it at the end of the presentation. It's the full text is available for free online. So that's a little bit outdated because it's 2014, or actually like early 2015. But the book chapter is updated with a lot of new information. So look for that book. It's being published by MAPS.
And I skipped over the disclosures, but Wes and I have not received funding from anyone ever.
And we should also mention that we both have private practices in psychiatry where we administer ketamine, so it's, we're not really getting any payouts from drug companies, but we are very interested in it, and we definitely do it in our practices. If you want to find out more about us, we have our websites listed here, Dr. Marta and myself. So I think, yeah, I can start this one out, Uncle. So anyway, I made an overview slide to kind of give everybody an idea of what we're going to be talking about here. There's a lot of information, so we're not going to try and cover everything in huge detail. If you want to know the intricacies of it, I invite you to check out that review article. But we're going to talk about a few different things, such as like what medications can be used clinically, what makes a drug according to the FDA. They're the ones who approve it, so how does that process work? So we're going to talk about that. We're also going to talk about what off-label use is. So that means once a drug is approved for something, off-label is an alternate use, something that's not approved for. And that's kind of where ketamine fits in. So we're going to talk a little bit about how ketamine fits in this whole rubric, as well as some of the evidence for its use. So to start out, we'll talk about controlled substances. So there's 5 different groupings of this. It's structured according to 1 through 5, and it's been based off the DEA kind of created this criteria. So Schedule 1 is the most restrictive, and this is what a lot of the psychedelic drugs fall into, like LSD and mushrooms. So they're considered to have no medical indication, meaning there's no particular thing that it can be therapeutically useful, at least as far as what the FDA says in terms of what it's been approved for. So no currently accepted medical use. And it's also got a high potential for abuse. So some of the examples in the Schedule 1 category are heroin, LSD, marijuana, and MDMA. And so MDMA currently is in that schedule, but with enough research it could be bumped to a different one once enough information comes out to prove that it does have this medical use. So these can only be prescribed in research studies, and it's very difficult to get that appropriate paperwork through in order to be able to do that. And for example, a lot of the issues around marijuana and cannabis is that it's very difficult to do this research because the paperwork burden is so huge. So it kind of prevents enough data being able to be accumulated to move it out of Schedule 1. Schedule 2 and down, or rather 2 through 5, are considered to have medical uses or medical indications. And they go down from Schedule 1 and 2 having a high potential for abuse or misuse down to Schedule 5, which is very low potential. So Schedule 2 includes a lot of stimulants like Adderall, Ritalin, and all the high potency opiates like fentanyl, methadone, oxycodone. And there's some controls in place that are required in order to prescribe it, like paper scripts and no refills. Schedule 3 has moderate to low potential for physical or psychological dependence, and ketamine is where this falls into in Schedule 3. Other ones in Schedule 3 are anabolic steroids and some low potency Tylenol with opiates. Schedule 4 is even lower according to the DEA, and that's like Xanax, Ativan, benzodiazepines basically, and some other miscellaneous drugs. Schedule 5 is even lower in terms of the potential abuse, potential like for substance dependence, and that's like some Robitussin formulations. And the majority of drugs out there that are approved by the FDA aren't scheduled at all because they're not really considered to have a potential for misuse. So what is off-label use? I talked about it a little bit earlier. Medications, when they're approved, go through this extensive review process by the FDA, Food and Drug Administration. So Cole's going to talk about that in a moment, about the different phases that a drug goes through in the research phases. So the indication, when I've been saying that earlier, Cole and I know what that is, but I don't know if a lot of people who haven't gone through medical school and residency understand. That's the particular reason for which the drug is approved. For example, ketamine is approved for induction of anesthesia or putting people under for surgery. So we're using it off-label, meaning not for the intended approved use in treating psychiatric conditions. So it could be used by any provider, any drug out there could be used off-label by any provider. There doesn't have to necessarily be a high level of evidence for it. But with ketamine, there is a lot of evidence to suggest that it is useful for depression. We're going to talk about that a little later.
And I think it's worth pointing out that off-label use is incredibly common, especially in psychiatry.
Yeah.
A lot of drugs that are approved for depression also prove to be extremely helpful for anxiety disorders, and even the majority of drugs that are prescribed for sleep originally weren't FDA approved for sleep, but proved to be helpful for sleep.
It's extremely common in psychiatry in particular.
So, yeah, we're going to talk a little bit about how a drug goes through the process of becoming approved by the FDA. Initially, we have the preclinical trials. Preclinical trials are tests with animals, tests other experimental tests about the drug itself. Phase 1 clinical trials is the first step where you're actually giving a drug to a human being, usually a small handful of human beings. You give the drug to establish different pharmacological parameters of the drug, also to make sure that nothing terrible happens to a healthy human who takes the drug. And so it's not being given to a large group of people. It's not being given to people for the indication that you're suggesting it be helpful for. Phase 2 trials, they're usually about a dozen of people to no more than about 100 people, I think, would be a large phase 2 trial. This is where like the MDMA studies are at this point. Phase 2 trials is the first time that you actually give the medication for the indication that you're proposing it'll be helpful for, and you're still establishing safety and trying to prove that it's helpful as you had predicted.
Yeah, and ideally the phase 2 trials include randomized control trials, which are kind of the placebo control, which are the gold standard, but sometimes they don't have that control. So it's really just, phase 2 is testing it for that particular indication and seeing if it has that effect or not.
And then phase 3 is where ketamine could be next if somebody were going to pay for the very, very expensive final step in the approval process. And this is what MAPS is currently raising funds for the MDMA-assisted psychotherapy for PTSD. It's usually hundreds of participants, if not thousands, and the idea here is still looking at safety, trying to find things that may occur at very low rates, and also proving that you can get the same results regardless of where the study is taking place.
Yeah, typically doing multiple different sites. And what Cole mentioned earlier, just we'll make a note of clarification. So ketamine has already gone through all these phases. It's been FDA approved for the anesthesia part, but nobody has done it yet for the depression part. There is I think Janssen is currently looking at a ketamine derivative for depression. So I think that's what you're referring to, Cole, right?
Yeah, exactly. So, and that's kind of, I think, important for the community to understand about ketamine is, now that ketamine is off-label and nobody stands to make the amount of money back that it would take to pay for a phase 3 trial, there's most likely not going to be a phase 3 trial for ketamine. It's going to take a derivative like ketamine to have the interest of drug companies that pay for those kinds of trials.
Right, because the derivative they can market and get a bunch of money for, whereas ketamine itself is a lot harder for them to have that get that potential payout.
So there's a risk that ketamine will be kind of perpetually stuck at this phase 2 level of evidence, even if it were superior to drugs that end up getting FDA approval, for example. And then phase 3 is what all drugs are considered to be in once they come to market. They can all technically be pulled if some very rare safety concern occurs that wasn't picked up during the phase 1 through 3 trials.
So where we are today, I'll talk a little bit about what psychiatry has done so far. I mean, currently, when we're treating depression, what we're doing is manipulating either the serotonin, norepinephrine, or dopamine receptors in various ways. Those are the monoamine neurotransmitters. Ketamine is really very new in that it uses a different method of action. It targets the glutamate system, also known as NMDA. I'll get to that a little bit later. But what we also know is that when we're treating depression, a lot of times people don't respond or get that improvement with even the first or second trial of the drug. And those are considered trials that are a high enough dose and long enough duration to be effective. For example, SSRIs, we know usually take weeks to kick in and really get to full effect. And that's just a limitation of how SSRIs work. Not that they're bad drugs or anything like that, but the interesting thing is ketamine seems to work much faster than that. So what we see is there is a lot of people with treatment-resistant depression, and it's people who haven't gotten the full response. They haven't gotten completely better, even though they've tried multiple different available drugs, and they've really gone through the ringer with their psychiatrists. So the new thing about ketamine is that it uses a different kind of molecular target, the glutamate system, And there's different sub-targets of that, like mammalian target of rapamycin, mTOR, and various other things like BDNF. So it's kind of novel in that way, and a lot of people in the psychiatric community are excited for that reason. They're also excited because it seems to work really quickly. About within an hour of receiving ketamine, people are much, much better in terms of both their depression and their suicidal thoughts. And it seems to work even in people where other medications have failed. Again, the treatment-resistant depression. And there is a kind of a criticism against ketamine that it may not last very long, but even if it doesn't last very long, it does provide people hope to see what it's like not being depressed. So, should I keep going, Cole?
Yeah.
So what we wanted to do was look at the scientific evidence for ketamine's use in depression and really kind of analyze it and see what's what. So we looked at evidence of efficacy in the treatment of treatment-resistant depression with a single dose of intravenous ketamine over the standard kind of dose and duration. That's 0.5 milligram per kilogram over 40 minutes. And that's really just what a lot of the trials have started out with, and it's been done and replicated a huge number of times. We also wanted to look at how do we extend the efficacy, because one of the limitations of ketamine is that it doesn't work that long. So maybe you can extend that duration by giving multiple doses in a row. We also want to look at the efficacy giving different kinds of doses. So instead of giving it intravenously, give it intramuscularly, intranasal, sublingually. We also looked at the efficacy of the R and S stereoisomers of ketamine. That's kind of derivatives of it. We'll talk a little bit more about that later. And its efficacy in reducing suicidality, as well as its safety and tolerability. So we looked on PubMed, which is a repository for scientific studies, and anybody can go on there and look at whatever they want. So we typed in ketamine depression, and almost 1,300 studies came up, and that's as of April. So probably by now it's at 1,400 or 1,500. And then we refined it further by only looking in humans. We excluded studies that used it in combination with electroconvulsive therapy and other kinds of treatments. And we also excluded like in-depth studies of biomarkers, neurocognitive effects, and neuroimaging like fMRI and other things like that.
So yeah, I wanted to put up this this slide too, because I think this is an important concept for everybody, especially in our community, who may engage with the scientific community or become frustrated in reading about evidence of the efficacy of some of these psychedelics, for example, and maybe being frustrated that they're not being taken incredibly seriously yet. So I wanted to kind of go through the way that the medical community looks at sort of levels of evidence. So the lowest level of evidence that you might come across is like an expert opinion. Anecdotal evidence, like case reports or case series, that's what we're seeing so far with a lot of like psychedelics, for example, so far. There are, ibogaine, for example, I would say is at the observational study level. That's looking at data from places where people are taking this, but it's not a setup trial, not being controlled, which is really the industry standard.
And it's not necessarily perspective, which is meaning you set up the trial ahead of time and say, we're looking for this particular marker of efficacy or not.
And then, so the gold standard for like demonstrating efficacy of a drug is the controlled randomized double-blind placebo-controlled trial. Sorry. And after several of those kinds of studies have been done, you can do a review looking at all of the trials that have been done, or a meta-analysis. And that's sort of what we wrote up, was a review of all of the existing, at this point, mostly phase 2 trials. So we ended up reading 77 publications for our paper in excruciating detail. 56 studies used IV ketamine, and we also wanted to look at some of these other factors that we talked about before, racemic versus the stereoisomers, alternate routes of administration, and also repeat dosing we wanted to look at.
I would also mention we also considered unipolar or regular depression differently from bipolar depression. And there's good reason to do that just because of the different response rates and pathophysiology of it.
So this figure is the results of our compiled data from all of the phase 2 randomized controlled trials for unipolar depression. And these are the time markers here on the bottom. We don't have the numbers, but it's roughly an N of about 60 for the group that received ketamine and about 30 to 40 for the groups that received placebo, or saline in this case. And so we compiled all of the studies and put them together, and this is the results that we get. A response rate is defined as a 50% reduction in depression scores on a validated measure. So you can see here, over 50% of people at 2 days are responding to a single dose of IV ketamine, which is weeks before an SSRI would work. And we're also talking about people who have treatment-resistant depression, which is notoriously difficult to manage. These little guys are the saline responders.
Yeah, so that's what happens when you give somebody just like salt water. They don't really get better. They don't know they're getting salt water or ketamine. Well, they can probably guess later on, but there's a big difference between salt water and ketamine.
That's great. Like 2 people did good after 40 minutes of salt water. The open label investigations, these are other studies that have been done. This is not a randomized double-blind placebo-controlled trial, but it is a trial where it is prospective. So you're giving people the drug, they're aware that they're taking it, and so is the person doing the study. So there is some risk of bias. However, when we compared it to the blinded ones, it's roughly the same results here. And a big difference between the two is the number of people. Open label studies are easier to do, so I think we had upwards of 200 in the first, in the group sizes for at least the first week or so.
One other thing I'll point out is you can notice over day 10 there's kind of an uptick, and that's just probably statistical noise because certain studies only measured certain time points. So when you see this graph, it doesn't really give you the full story. It's just kind of a very kind of a shotgun blast through the data.
Yeah. And even though the average length of response for an individual was at least somewhere between 5 and 7 days from a single infusion, it is interesting, I think, that even at 4 weeks, about more than a third of the people who do respond are still seeing greater than 50% reduction in their symptoms. Okay, so this is a similar graph, but for bipolar depression, which is a bit of a different monster, and has some unique clinical aspects that that you have to worry about that you don't have to worry about with unipolar depression, and is clinically a little bit more difficult to treat classically. So it's very exciting to see similar results with bipolar depression, and very exciting to see that it was the data is similar to the unipolar depression.
Yeah, and so if you notice the first 4 time points, there's no orange bar. It's because nobody got better when they received saline. They only got better after they received the ketamine. So arguably, and it's consistent with our clinical experiences, that bipolar depression tends to be harder to treat.
Yeah.
Are you taking questions at the end?
Yeah, we'll take questions at the end.
Yeah.
And again, this is the open label investigation, as I explained with the unipolar depression, but with bipolar depression, again, larger numbers reflecting basically the same outcomes. I'm sorry, this is repeated infusions. I'm sorry, that was not. This is an open label from bipolar 2. This is repeated dosing. So one of the things that we were extremely interested in, because of this criticism of a single dose only lasting 5 to 7 days, well, nothing that we use for depression do we give a single dose of. Like, the reason there was a single dose studies came first was to establish safety. Now with repeat dosing, it's showing that we can extend these benefits. These people, most of these studies were twice a week, some of them were 3 times a week. This is the compiled data of the response, and we had similar overall responses here, reaching 50 to 60%. And then this is the number of days after the final treatment that they continued to see benefit.
Right, so some of the interesting parts about this chart is that you see increasing levels of response in general with an increasing number of administrations. So the more administrations you give in a row, the greater benefit there seems to be. And we can also see that after receiving multiple administrations, the effect tends to stick around longer than after they receive only one. Yeah, so we also looked at alternate routes of administration. So this slide talks a lot about the intramuscular data that we reviewed. So there was 31 patients that we found data on who received intramuscular injections. And there was one randomized control trial, one open label study, and a lot of different case studies. So the randomized control trial looked at a total of 5 patients, not that many, but they found response in 3 of the 5. Versus with the control, they found 0. The open label looked at IV compared with IM and different doses of IM. And it found essentially similar response rates between IV and IM, implying that intramuscular and intravenous administrations are probably both about as effective as each other. This is kind of important to note because in a lot of ways intramuscular administration is a lot easier to do than it is setting up an IV and a drip, though honestly it's not that hard to do an IV infusion either. So intramuscular studies here also seem to be different from the IV studies in that a lot of these cover multiple administrations. Some of them even reviewing cases where people were maintained free from depression out for a period of time of months, 6 months, 8 months, a year, or even longer than a year. So it's really exciting because it's some of the only long-term data we have on ketamine.
I just wanted to also mention that another reason this is of interest is that the equipment needed for IV administration, even if it's not necessarily terribly technically difficult, it raises the cost and decreases the availability of the treatment.
And also the issue of patient comfort too. Arguably a little bit more comfortable just getting the injection at the beginning versus keeping an IV line in. Intranasal is another route that's been studied, though obviously a lot less so than intravenous. There's one randomized control trial of intranasal ketamine, and it seemed to have a comparable response to that of intravenous. Around 44% of people had that response. And that was like through 2 days after receiving a single dose of intranasal ketamine. There's also a trial with a series of 6 to 19-year-olds with bipolar disorder given various doses of ketamine. It seemed to have a rapid onset and last several days. And this study was notable that they gave multiple doses a week, like 2 doses a week, and they maintained people free from depression for prolonged periods of time.
Children.
Yeah. Children with severe bipolar depression, so it's definitely they're trying something out in a refractory patient population.
I believe they were all these were all inpatient cases too. I think it was on an inpatient facility.
Yeah, there's also data on sublingual, meaning under the tongue, subcutaneous, that's kind of an injection right under the skin, not in the muscle tissue, not in the vein, oral, meaning by mouth. So these also have some evidence, not as much data as the other routes of administration, and they all have shown some success. The notable thing is oral administration does seem to take a lot longer to start working, whereas all the other routes of administration seem to start working within an hour or so. But maybe oral administration has less side effects, less of that psychedelic aspect to it. So why do we care about these alternate routes? We kind of touched upon it earlier, that it's potentially a new way, an easier way to administer ketamine to a larger group of people, more comfortable for the patient. Another thing that isn't talked about all that much is this existing dose and duration of 0.5 milligram per kilogram for 40 minutes. That's how most of the studies have been structured, IV infusion of that dose and duration. It's kind of an arbitrary value. We don't know that that necessarily is the right dose level or time. It could be lower, it could be higher, and so it's important that we study other administration routes and other doses.
Oh yeah, so in our review, we just kind of touched on this subject. There's R versus S ketamine. Stereoisomers are like your hands, the fact that they look like mirror images of each other, but you can't superimpose them. So the ketamine molecule in 3D space has a different arrangement of the individual elements, the individual atoms. So there's some question about whether maybe the right-handed one is more potent or helpful or causes more side effects than the left-handed version. The majority of the studies we looked at used racemic ketamine, and though we looked at this, there was a real lack of data. We didn't find anybody had taken R ketamine. Very few people had been giving S ketamine, and basically it was kind of inconclusive about whether S ketamine was more helpful. Some studies said the S ketamine was beneficial because it had less side effects. Other studies said that it had more side effects, so it was just another thing that we looked at because it's of interest, but there wasn't a lot of data.
Also, I'll note, I don't know that we defined it, racemic ketamine means like a 50-50 mixture of S and R, and that's what you usually find when somebody's talking about ketamine, it's racemic ketamine. When you purify that one-handed version of it, that's S or R, depending on which hand you look for.
So you guys use the R?
Racemic ketamine is a 50-50 mixture of the R and S form. It is kind of confusing because it's an R also, but I believe it has something to do with Latin right hand versus left hand.
Yeah, so we also looked at ketamine and suicidality. Most of the data looking at this was secondary, meaning a lot of the studies were actually looking at treatment of depression for ketamine, but they also went back afterwards and kind of reanalyzed the data for suicidality. And so it's not as, should we say, like strong because it's not a prospective trial, but it does seem to have a benefit. One study did look at this prospectively, the effect of ketamine on suicidality. And pretty much the majority of studies have found that it rapidly reduces suicidality. That's another potential indication for ketamine is being used in the discharge of people from psychiatric emergency rooms earlier because you can potentially treat their suicidality instead of have to keep them longer. So is this effect of reducing suicidality unique to that, or is it just a side effect of treating the depression? No one really knows. There's kind of conflicting evidence either way, but it's still kind of being worked out. It's also important to know that there's not many drugs out there that have been shown to have a potent anti-suicidal effect. Pretty much lithium is the only other one out there. So ketamine it's pretty amazing knowing that ketamine has this effect as well.
And with lithium, which is the only other drug that's been shown to have some effect on suicidality specifically, that it only separates from people not using lithium as far as being statistically significantly different from non-lithium users after like 2 years of using lithium. So for the first 2 years, roughly the same risk of suicidality whether you're taking lithium or not. Long-term lithium users are at a decreased risk compared to long-term other users or non-lithium users, whereas we're seeing this effect in 40 minutes to 4 hours or 1 day.
Yeah, it's pretty amazing. As a psychiatrist, it's a pretty amazing finding.
Oh, okay, so another thing that we looked at in our review was any potentially adverse effects. Primary adverse effect most common things that they saw, other than change in perception, which we'll talk a little bit about, is hemodynamic effects. So in about a third of people, there was an increase in blood pressure that was statistically significant, meaning they could statistically attribute the change in blood pressure to the ketamine. However, there is some ability to confuse that with clinically significant. It's a slight increase in blood pressure and heart rate. It's measurable, but it's not terribly significant. Well, the hemodynamic effects are resolved within about 4 hours. Rarely did they ever require treatment, and when they did, they responded to basic first-line treatment.
It's also important to know that when we're talking about the hemodynamic or the effects on the heart and blood pressure, this is at low-dose ketamine being used for depression. When you use ketamine for anesthesia, it has, just because the dose is maybe 5 or 10 times higher, it has much more hemodynamic side effects.
One thing that is still kind of an unanswered question about this repeat dosing concept is the lower urinary tract symptoms. None of the studies that we looked at demonstrated this phenomenon called LUTS, the lower urinary tract symptoms, which is that basically high doses of repeat ketamine has been shown in the abuse population, which the studies that looked at this defined abuse population as people using upwards of 1 gram a day most days for extended periods of time, and also typically polysubstance users. In that population, they found this phenomenon, but they haven't found it in any of the studies we've reviewed. So it's hard to know, when does this toxic bladder issue come into play? Is it after 10 treatments, or is it after 1 gram a day for 10 weeks? That's something to keep an eye out for as the literature grows. So the other effects of interest maybe to the group is the psychotomimetic and dissociative side effects. Psychotomimetic effects are measured in these studies by a scale used to measure psychosis. We'll talk a little bit about why that might be a misnomer later. And then the dissociative effects, feeling of depersonalization or being sort of away from your body. They use scales to take a look at those, and the ketamine groups did show statistically significant differences between the ketamine and placebo groups with regard to those scales.
They basically prove that people get high off ketamine, which is probably not a surprise to many people.
Right. And there has been some, this giving it a 0.5 milligram per kilogram spread over 40 minutes. I think that strategy also, there was hopes that it would kind of dampen down some of that unwanted dissociative and psychotomimetic side effects.
I think the Mayo Clinic gave over 100 minutes, and they said it was mildly less. So.
Right. And some of the drugs that are coming to market that are sort of copycat drugs, that's what they're claiming is their benefit over ketamine, is it doesn't have this pesky psychotomimetic and dissociative side effect. Fortunately, it also doesn't work. And then here's sort of the other side effects that I would say were common enough that it's worth knowing about. Maybe the kinds of side effects that occur in maybe 10 to 15% of people.
So yeah, talking about psychotomimetic, as Cole was mentioning earlier, that literally means mimicking psychosis. That was kind of a rough term given to a lot of these substances early on. It's probably more apt to call these psychedelics or mind manifesting. So it depends on how you measure these effects. I mean, what we're seeing when we give people ketamine is that they feel different, they have these different experiences. And if you apply a rating scale that measures psychosis, then it says, yeah, these people are, quote, psychotic. If you apply another measure, rating scale, like there's a 5...
5DASC? 5 dimensions of altered states of consciousness scale.
Right, so if you apply that scale, it actually comes out to be a psychedelic. So it's really sort of how you look at it and how you perceive it. And if you want to call it a mimicking psychosis, you could. I don't know that it's really accurate. Certainly people will have different kinds of thoughts on it, but I think it's more apt to call it a psychedelic.
And this is a historical issue too, when the first psychedelics were being studied and when LSD was discovered and then psilocybin was being looked at, and before 1970 really there was a lot of inquiry into psychedelics in the world of psychiatry. And originally this whole class of molecule were called psychotomimetics because they thought that this was a model for psychosis, and they were even using it as a model for psychosis. They would give it to people to intentionally induce a psychotic state to see what kinds of treatments work for psychosis. And found out all that research was kind of void because the psychedelic state is not really like psychosis. There's some overlapping features. And that's, I think, my expectation is that that's the reason for people having significant scores on their psychosis scale is more because of an overlap in symptoms between psychedelic and psychotic states.
Yeah, definitely. Yeah, and so Cole touched on this earlier too, that it's been other NMDA receptor modulators have been looked at too, and they generally found that drugs that work on the NMDA receptor that don't get people high don't seem to have a benefit for depression, while drugs that do provide some kind of psychoactive effect, meaning people feel different on it, like nitrous oxide or dextromethorphan, do seem to have some benefit for depression. So it kind of begs the question, like, do you need to have this kind of psychedelic component to a drug in order to have the benefit of depression? And it's not entirely clear. I mean, there's some newer studies of ketamine derivatives that may be still useful for treatment of depression but don't have the psychedelic effects, but it's inconclusive right now. From what we know now, it seems to be leaning towards the need to have this kind of psychedelic aspect to the experience in order to get a benefit.
I think more to get a maximum benefit. I think with ketamine, there is benefit to ketamine even when people don't report having psychotomimetic effects. For example, with the oral ketamine, people don't tend to have a psychedelic experience, and yet they're reporting benefit. But it does seem to be, I think, the way to think about it is that the psychotomimetic and dissociative side effects may add a second mechanism by which it can either affect people who aren't affected by just the kinetics of it and the pharmacokinetics of it, the pharmacology of it, or maximize the benefit for those people that do.
Right, the psychedelic aspect may be independent from the biochemical one in terms of benefit for depression. And it's kind of what we see too with some of the studies in other psychoactive drugs like psilocybin, MDMA, and ibogaine that seem to have a benefit for other sort of psychiatric indications. Yeah, and kind of what Cole mentioned also, the degree of dissociation and the degree of psychedelic effects or the magnitude of it doesn't seem to correlate either with how much benefit people receive from it. We've found data both ways. That some people say very much so, this is correlated, and people say not. So the jury is still out on that. Yeah, and set and setting is something that hasn't been controlled for a lot with ketamine, whereas it's something that has been very much focused on in studies using LSD and MDMA. So it's something I think that could be improved in the use of ketamine. I mean, creating a good environment when it's administered. A lot of these studies have given ketamine in a post-op recovery room where it's kind of a noisy environment, there's nurses running around. It's not going to be the most soothing to somebody. It's not a relaxing environment to spend time in.
Right. And again, you know, some people looked at trying to correlate the dissociative scores with the benefit, and that was inconclusive. And my question still remains that if we used a scale that measured the psychedelic experience, the degree of mystical experience achieved, would that be a better predictor than dissociation or psychotic scales that may give you variable outcomes when trying to make the correlation because you're using kind of the wrong tool? And setting, you know, if somebody, a lot of the studies are done at, you know, research institutes, hospitals, not a typical ideal setting for that kind of an experience. So they may have had a very dissociative experience in a very spooky place. So that's not expected to be helpful.
I just want to ask Ashley, how are we doing on time? Do we want to be, or should we be done in a few
Yeah, you
minutes?
guys have about 10 more minutes.
Okay, well, we're at the summary, so good. So basically, just to kind of summarize what we talked about here in the presentation, ketamine has been shown to be very effective for treatment-resistant depression, where a lot of other treatments, standard in psychiatry, have not worked, both in unipolar and harder to treat bipolar depression. One limitation of ketamine is that it may not last very long. You can give only one dose, but no treatment in medicine or psychiatry really does that, unless you want to call them the antibiotics. But we found that if you give multiple doses in a row, it seems to extend the duration. It also seems to reduce suicidality, which is an extremely exciting finding for psychiatrists to hear about. We also found that the IV route of administration is the most studied, most data behind it supporting it, but the other routes of administration also seem to work really well.
I like to say, you know, the IV administration has the best quality of evidence, but there isn't evidence that it's the best way to do it.
Right. Ketamine treatments seem to be pretty well tolerated. They have these psychedelic effects and some effects on blood pressure and heart rate, well tolerated at least in the doses used for treatment of depression. There does seem to be a connection between very heavy use of ketamine and people who are abusing it and urinary tract symptoms, but not really in the clinical population where it's being used and prescribed by a physician. But being used more than it should be, that can be a definite concern for a variety of side effects. And a lot of people in the psychiatric community seem to focus on the dissociative or these kinds of psychotic effects of ketamine. But in practice, most people enjoy the experience. They don't find it distressing. It doesn't really lead to people not getting ketamine. There is a minority of people who find it unpleasant and don't continue, but the majority, it's not an issue. And really, these sort of psychedelic effects could be harnessed as a way to process some kind of subconscious phenomenon and go further with therapy.
Yeah, and I'd just like to hammer that home. These psychotomimetic and dissociative side effects, when people, you know, in discussion articles and opinion articles, often make it seem as though there's a big desire to get rid of these unwanted effects. But we looked at hundreds of participants in studies with ketamine through all routes of administration, and there were single-digit number of people who stopped the treatment due to the psychotomimetic or dissociative side effects.
Yeah. So we're thinking about including all the references for our talk, but there's more than 150. So if you want to look at them, you're welcome to go to the original article. And here's a link I was talking about. It's on the CIIS website. So we can leave this up for you guys to look on. And the book references there too. So I think we probably have some time for questions. Just cut us off whenever we need to stop. I think you had your hand up first.
So you talked primarily about depression. Have you noticed, or is there any evidence that it's beneficial for, say, anxiety or other conditions? It said, you know, addiction, perhaps, some of the things.
Right. There's a lot of literature in, I believe it's the Russian anesthesiology literature. Somebody's treated thousands of patients with alcoholism, and one of the godfathers one of the godfathers of Russian psychiatry, Evgeny Krupitsky over there, that was the original indication that he was using it for. He was actually doing ketamine psychedelic psychotherapy specifically for alcoholism.
Yeah, and opiate addiction as well.
And another indication that's been looked at is a very well-designed study of the same caliber as one of these depression studies, and actually done by one of the same groups. Looked at ketamine for treatment-resistant PTSD, and they had similar outcomes.
So would you recommend it for addiction, let's say, for anxiety and addiction, alcoholism particularly?
It would be a case-by-case basis. There are a lot of variables in all of those diagnoses.
And I'll stop asking questions, but is there an age? Like, I have a son who's 25, he's just not getting it. And there's speculation the brain hasn't completed, the myelin coating in front of the lobes is not complete, and that maybe at 26 or 27, he'll get that more sense of mortality, that he has to, sober up. I mean, that's my hope.
I hope so.
Well, there's anything on that.
And as far as any issues with regard to ketamine and that process, I haven't heard of it causing any kinds of problems with that.
For the shot.
They have ketamine is actually like there's an anesthesiologist here who could say if I'm talking out of my rear end or not, but I believe ketamine is a go-to anesthetic for child anesthesiology because of its enormous safety window.
Yeah.
That's correct.
Excellent.
I have a question. So I found it odd that when you were comparing like IV infusions to the other routes of administration, that although they all may be effective at some point, that IV infusions really are the only ones that are fully controlled.
For the studies, I mean.
Yeah. For instance, if you were to turn off an IV infusion, if it's intramuscular or oral, you can't just turn off the ketamine.
Yeah, that's true.
So if you're
You
talking
have a greater control over the blood concentration of ketamine at any given moment if you have an IV infusion. You still would have a similar elimination half-life once you do decide to stop it. So yeah, I guess there would be a risk of if somebody were having some terrible response to the ketamine and they were still on their ascension with the intramuscular, for example, but we haven't seen any such disastrous things to be concerned about.
And I think you're talking about control of the blood serum concentration, if I'm correct. Not talking about control of the trial, like with placebo controls. Is that right?
Yeah.
Okay. Because there are some controlled studies looking at intranasal and intramuscular, and that's the gold standard.
Yeah, no,
Yeah, she's talking about being able to more fine-tune.
you were just saying as far as effectiveness between, I think there's more factors to look at than just.
There, I think it's
There's a lot.
Never mind.
Yeah, there is. Yeah, that's a good point.
So, I'm not familiar with the practice of Cole, and I'm slightly familiar with yours. When using ketamine to treat in like a ketamine-assisted psychotherapy, what is the psychotherapy protocol and evidence-based practice that tends to be most effective with treating depression? Is it short-term, long-term, weekly, CBT, DBT? Like, what do you find to be most effective?
So I'm happy to answer that question, but there's no studies or there's no like data on this.
It's extremely limited, yeah.
Yeah. So in my experience in talking to the community of people who utilize this, not even everybody uses psychotherapy. The ones that do whatever type of psychotherapy they're best at. Some people become really, really good at one particular style of psychotherapy, and I would argue a skilled therapist at whichever style they're good at is better than picking a style and trying to get everybody to work that one.
Right, so providing psychotherapy independent of ketamine seems to work to treat depression and a number of other things. So if you do, like when Cole and I, when we do sessions, we typically schedule enough time to give a ketamine injection as well as do psychotherapy. And so you're kind of, what we're doing is adding on the psychotherapy because we have the time already there with the kind of hope that the psychotherapy sort of boosts the response.
As far as like the style, I you kind of the style that I learned in the work with the MDMA-assisted psychotherapy.
Okay.
And then I know some people who do like Jungian kind of analysis, and others that do attachment theory style.
Great.
All with you know.
So really non-directive.
Yeah.
Okay.
And each of those seems to have better outcomes than we're seeing in these studies.
Is the psychotherapy that you're doing, it's not while the person's on the ketamine, it's prior or post, or how are you doing it?
Correct. It's either before
Wait,
or after.
Wait, or before or after with your patient, so it's not necessarily protocol that you always do it before or always after?
Right, right. If something is, I mean, that's just kind of the free-form nature of like the appointment for me particularly. I don't have like a rigid structure for the appointment as long as both happen. That makes sense?
But is
Also
it
do-
while they're under that they can actually be utilized in psychotherapy, or are you out because somebody here said that they were just out completely?
Yeah, during the effects of the ketamine itself, they're incapacitated. Would be a very one-sided conversation.
Yeah, it's a subtle question because you know, with a high enough dose of ketamine, people are knocked out and they're not going to be able to talk in full you know, sentences and really make a lot of sense. But there's that sort of window period where they're kind of sobering up. They're not totally back to reality, but they have some effects of the ketamine. Some of the psychedelic effects are still lingering. And I definitely try and engage people during that phase of the sort of pharmacokinetic aspect of ketamine to get them to consider things and talk about themselves during that part.
And typically, during the effects themselves, I encourage people not to try to talk and actually use eye shades and headphones.
Yeah, usually I've found that it's like maybe a good half hour that people, or sometimes even 40 minutes after the IM injection, that people are probably having too much effect, so they can't really talk that well.
Right.
And you're generally doing 0.5 milligram per kilogram, or?
Yeah, is the ion different?
Mm-hmm. Yeah, that's a dose that I use.
What dose?
Half a milligram per kilogram body weight.
Yes.
You mentioned that the psychomimetic or psychedelic side effects, which some people think is pesky, may be a very important part of the transformation that sometimes takes place when people receive ketamine. Is there any study on that you want to talk about?
So that's kind of, that's the very personal question to me that I've been trying to answer with my entire like research, is what drives my research interest. And we're really close. So there's these studies that we looked at, and this, you know, scale that's not quite what I want to see. And there is, Salon Dr did demonstrate that ketamine does produce the mystical effect, because he's validated, he's used that scale to demonstrate that ketamine, along with several other Schedule 1 substances here, produce those effects. So just stick those together.
Who is the researcher you're mentioning?
Friends of Wallenweider. It's
Switzerland, is that right?
VOLLEIDER.
Yeah,
And
you can find
search the means W.
You can find a reference. It's in our, if you pull up the full text here, the link is.
Wallenweider or Wallenweider?
It's definitely like a VOLL.
Definitely Wallenweider. It's pronounced Wallenweider, but one of them's a V and one of them's a W.
I think the first letter's a W.
Okay. Apologies to Mr. Wallenweider.
When you reviewed the bipolar data, did you find anyone switching to mania that you suspected could be related to repetitive?
That's a really good question. So one of the things that when you treat bipolar depression, you always have to worry that you're going to trigger a manic episode or switch them from depressed to manic. That's what makes somebody bipolar versus just unipolar regular depression. And we didn't really find too much data that supported that it switched.
And actually, I wrote a case report shortly after this because we saw some behavior that was like a mania in an adolescent who was being given ketamine for a dental procedure. Had received ketamine twice for a dental procedure, one for an exam and one for a procedure. And that was a patient who had severe prior brain damage, significant spastic cerebral palsy, for example. And so in the review of the literature for that, even people with cerebral palsy, that was a review from the anesthesiology literature showing no episodes of mania having occurred in, I think, 30,000 cases or something like that.
I think there's some questions back there. I don't want to miss anybody.
I forgot. Are there any, in terms of people getting off medication after doing this, how has that been? You talked about that before.
Well, so there's multiple strategies. Like in order to extend the effect of ketamine, some people have been given an SSRI right after they give the ketamine infusion to see if it'll kind of boost the time to onset. So ketamine gets people less depressed immediately, whereas the SSRIs take a while to kick in. So that's one strategy that's been used. But I think what you're asking is, how do you get people on fewer medications?
Right.
So a lot of people have a preference to not be on psychiatric medications that they take every day. And it's certainly a possibility that you can maintain somebody after an initial course of ketamine on maintenance treatments. But I always try and encourage people to get on a medication that's potentially less risky, like an SSRI, just because we know that the data is good for long-term treatment of depression with an SSRI, whereas with ketamine, it's sort of an open book at this point. We don't know the whole story yet. I don't know if you have anything to add. Cool.
I don't have anything to add. I think it would be that kind of decision is always on a case-by-case basis and almost daily basis of what's going on and how they got to the medications that they were on in the first place. Are they on the wrong medicines? Was it a misdiagnosis? Or, there are lots of things that go into that, but I don't see anything about ketamine that guarantees something like that.
It's certainly possible.
Do you see people get off their medication by doing these types of treatments?
I've seen people who were on SSRIs before and maybe had some benefit, but ultimately decided it wasn't worth it for them. So they their depression came back, and then they came to me to try ketamine, and with ketamine they've been able to be free from their depression and not have to go on an SSRI. So it's certainly possible.
Two quick questions. One, I thought you guys had said at one point, talking about bipolar depression, that you said it was a little bit harder to treat than unipolar depression, and then I thought the very next slide it was pointed out that the data was quite comparable. So I was just curious for a little bit more detail on that comparison.
Sure. So bipolar depression is notoriously difficult to treat with traditional treatments for depression and bipolar depression.
Got it.
It's a bit harder in general to control, also a little harder to diagnose, and you have to run this risk of manic switch with the majority of the treatments available for unipolar depression. And that's important because a lot of things, but one important thing is when someone comes in a depressed episode, you don't know if they have bipolar or unipolar depression unless they had a really good relationship with a previous psychiatrist and have a long history of tracking that kind of thing.
All right, we got time for one more question. Who's had their hand up the longest? Cool, you decide.
Wait, you forgot me.
Yeah, so is there any risk to you or other doctors doing this for off-label use? I think about a friend of mine who's bought for alcoholism treatment, and that was I feel like similar. It's not prescribed, it's not intended for that, but it somehow has this kind of underground success within that community.
Yeah, baclofen has an evidence base for treatment of alcohol use disorder. it's sort of the same thing. Ketamine maybe has a worse rap, like more of a stigma to it, because it is a drug that people get high on, and some people do get addicted to it. Though we haven't really seen that in clinical trials with depression, or with studies with depression.
I guess my question is, how can you guys do this?
Because it is available as an off-label indication. I would argue there is no drug for which there is more evidence for treatment-resistant depression than ketamine.
Right, arguably a good thing to use instead of electroconvulsive therapy, which is reserved for the most treatment-refractory cases of depression.
And so,
but I think what you're asking is like, what's the liability risk, right? And I think a lot of physicians and psychiatrists are very worried about prescribing ketamine, and anesthesiologists and ER docs are worried too, because there isn't as much of an evidence base to say that this is like an FDA-approved treatment, and it's something that has a lot of stigma, and that combination scares a lot of people off. So what we found in the data is that it is really useful, and we're kind of willing to say we really believe in this. Probably because we read like hundreds of articles about it. Whereas most people they're not that comfortable with it to say, okay, I'm going to take the plunge and just do it, even though the thought leaders of psychiatry are saying it's not ready.
Yeah.
So off-label doesn't really mean illegal. It's not.
Correct. Off-label does not mean illegal.
I think that's
off-label. You have to have. You just have to have evidence to support yourself if someone were to raise a concern about it. You'd have to say, this is the reason I think this might be helpful for this person. Read my 40-page paper.
Right. I mean, we could, for example, prescribe ketamine off-label for hair loss. It's probably not a good idea because if somebody has a problem, they're going to sue us and they're probably going to win because it doesn't make any sense to use ketamine for hair loss. But any drug that's FDA approved, physicians can use it for any reason they think would be useful. And then the sort of the liability risk is greater. Because instead of having the shortcut of the FDA approval, saying the FDA gives a thumbs up to treat depression, let's say, you have to kind of read the data on your own and sort of make that very difficult decision if the benefits exceed the risks.
And so most people who are providing it are taking a lot of precautions. For me personally, there's no take-home ketamine. Everything is done in my presence, in my office. A pretty extensive protocol. So, everybody has to do what they can to be comfortable in that way. And I think it's unfortunate that there isn't yet some kind of certification or something like that that could help protect in that way. There have been a couple of case law reports at this point brought against some people, and nothing's been successful yet against the doctors.
Thank you. Oh, we're out of time. All right, thank you guys so much.